Okay, so I know I got like probably 50 emails from various people. They loved it, so I'm going to say it again, not to mention the fact that I have waited at least 6 years to be able to say it. So therefore, I'll say it again. In patients with acute ischemic stroke due to large vessel occlusion, rapid endovascular treatment using stent retriever is now the standard of care. So there. Okay, you've heard some amazing stuff. So bottom line is endovascular treatment works, and it works big time. NNT of 4, 3 on shift analysis, those are not common things in medicine. I wrote this editorial a while ago in Stroke about the idea of parachutes and a philosophical term, epistemology, which is like, how do we know what we know? And it leads you to think about what Elad mentioned earlier. It is a real struggle to randomize these patients. This is from the ESCAPE paper, and it works on all subgroups. And it works whether TPA is given or not. The upper one is from Swift Prime, the lower one is from ESCAPE. And Solitaire is safe and effective. Multiple trials show very low complication rate. Clinical results speak for themselves. And the bottom line is either produce high quality data or follow high quality data. Collectively, we've produced high quality data. Now we should follow the high quality data till we come up with another set of questions that we produce high quality data for. There is no point at the current moment going into those minor discussions of A versus B or this works better than this. There are many other bigger things that we need to solve, and I'm going to spend some time talking about the bigger things that we need to solve and not worry about. In fact, to tell you the truth, this question of multi-phase CTA, CT perfusion is overall a very small question. It doesn't really matter. Take patients with small core, work fast, open the vessel. That's what all the trials show. Let's follow it, let's implement it, let's get it done. Those are things that, Bruce and I can arm wrestle about. That's a sideshow. That's not the main show. The main show is get the vessel open, choose the patients right. So it's important to realize that and not get lost in the minor message, concentrate on the main message of that after a long time we come with this results which conclusively show that there's a paradigm shift and we need to spend the resources, the time, the energy to implement it well. Now, time is brain. Like I usually don't give a talk without utilizing Jeff Saver's slide, and I show it in every talk that I give. This is a known. This wasn't the interesting part. The interesting part for me was that across 50 centers, Swift Prime ESCAPE, multiple countries, varying health systems, it can be implemented. So that is sort of the big thing which I was impressed with. But there was a problem here. I do think that the use of medians for anything that is related to time, in my opinion, is goofy. That's not what we should be doing. To my mind, it is incorrect. We should be using 90th percentile. And when we are reporting results, we were eager to show that we were super fast. And Michael and I discussed this at length, and we talked about it. To my mind, this idea of reporting times as medians is wrong. And why is that wrong? What about that poor patient that the hospital is saying our median is this much, but that means there are patients, or even if your median is 50, in which that particular patient is taking 100 minutes, and that particular patient is not getting advantage of the technology. What is more important to take those patients in which you are 100 minutes and bringing them to 50, rather than take the patients who are at 50 and bring them down to 40. So to my mind, I'm going to write about this probably with some of you in the room, but the idea of reporting medians for anything that is related to time parameters is to my mind, not a good way of representation. Now, it isn't over yet. There's still many battles ahead. And the first one, which is going to happen, Jeff and I were just talking about it, is changing the guidelines. There'll be some kind of statement that'll come out. And obviously, from a statement standpoint, there'll be the statement people try to make it in terms of really evidence-based in general. And it does help in moving the process forward. But there are other things that will need to be done. There's simple things like, for example, patient education. So patient education, patient's family education, and understanding of what is happening to my loved one sort of thing, that needs to improve. But another thing that needs to be improved as we go forward, aging population, this technology coming in, is the idea of advanced directives. So I'll tell you a story. A 59-year-old patient comes to the hospital with a stroke, and he's a professor of philosophy in the university. And he's got a left-sided stroke, aphasia, right hemiplegia, M1 occlusion. And this is before escape started. So the wife says, okay, can you get the speech back? And we say, well, chances are no, because the Broca's area and all is gone. So, but the upper area looks quite fine, and we should, she says, no, he wouldn't have wanted to live. So that brings me to this other point of that the use of modified Rankin score is great from the point of view of presentation of data and from the point of view of policy making. But there are many other complexities to the practice of medicine. And that is something that we shouldn't forget in terms of whom we are treating, when we are treating, and what is the best possible outcome, and what would the patient have wanted. And that is, again, something that will have to refine itself. You know, we were talking at home as I was thinking about it, and I said, well, what is good outcome? So I'm going to tell you a quote from my wife. And she said, if you have a loving family, MRS 3 is good enough. And if you are grumpy and alone, 2 is not good enough. So that's another component that one has to think about in terms of what is it that we're dealing with. And ultimately, we want to provide good outcomes of what the patient would perceive as good outcome. Not that, okay, well, you can go lift up your hand and you can move and you can stand. Great, checkbox under this thing, it's MRS of 2. And then we say, okay, we were successful. So that is something we have to be sort of cognizant of. We do need to fix systems of care and transportation systems. I'll come back to this issue in a minute. But the issue of training. Now, one of the things that we really struggled with is that it's a bad arch, it's a left-sided, this thing, and I'm sort of going there, there's a fellow with me, and I'm thinking I'm focused on speed, speed, speed. I feel very confident that I can be faster than my fellow in getting into that left-sided arch. And then I say, okay, well, move out of the way, let me go, let me sort of get the vessel open. But that brings up the question, then how does the next generation of people learn? And that is something that I don't have a very good answer for, but it is something that the industry needs to think about, that how do we create systems in which angio training can be provided in a non-human kind of situation to get used to the idea of the feel of the catheter, the fine touch, how do you get into a tortuous left common carotid artery. And as you know, real angio experience is just decreasing simply because alternative technologies have come in. Now, the other part which has come up is who should do this? The first part is you need to have a team. I don't think that just because you have the capacity to do groin punctures and put in stents here and there, you can just say, okay, well, a person with stroke comes in, CT angio seems easy enough. I can have an automated some map that tells me core is small and penumbra is big. And I know brain anatomy, or brain vessel, heart vessel, perifemoral artery, it's all the same. Let's just go open it. That, I think, would be the wrong thing to do from the overall stroke care point of view. So first part is team. The second part is the realization that brain is unique, and brain is not like any other organ in the body. And you know, there's this quote that one of my friends used to say, never have respect for an organ that can be transplanted. So the bottom line is, you know, the heart, whatever, liver, this, that, and the other, they're just different. They are there to keep the brain alive, okay? So the brain is the brain, it's different, it's something to keep in mind. Now the other thing we in Calgary are going to be focusing on a lot is, so to speak, the rebirth of neuroprotection. There have been like, whatever, 20,000 neuroprotection trials that have been done, none have been successful. But why were they not successful? Because we didn't have a good way to open the vessel. So if you think about it from a rat experiment, a rabbit experiment, monkey experiment, if you think about it, a permanent MCA occlusion model versus a temporary MCA occlusion model. I'm not sure if I saw Mike Timiansky earlier. I'm not sure if he's still in the audience or not. But if anyone wanted more details on that, like he's sort of the world guru on this idea of temporary versus permanent MCA occlusion. And you know, this afternoon we had coffee together, and he was telling me about this, that the neuroprotection will have its rebirth in this new paradigm. So if you think about it, in the world of solitaire, in the world of this data, essentially we now have a model of temporary MCA occlusion. And now we in Calgary are going to be focusing on it a lot. Now this is what the patient has to go through. Recognition of stroke, you've heard me all say this before, call 911, paramedics arrive, reaching to the correct hospital. We are very fortunate in Canada where this is not a big problem, but as I traveled around the world, many parts of the world, this is a big problem. ER assessment vitals, then you go to imaging. Either you can do it in 3 minutes like we do, or you can do it way, way longer and get some interesting maps. Go to decision making. and finally get to the cath lab, groin access, and sort of open the vessel, okay? This is all that needs to be done. But there's a problem. The problem is this thing which I call denominator fallacy, which I published in AGNR a little while ago. We say in ESCAPE we had 53 or 54% good outcome. In Swift Prime, we had 59% good outcome. But 59%, what is the denominator? The denominator is the patients who went to the cath lab. And that is something which is really important to remember. So imagine two cities, Gotham and Metropolis. Both of them have similar population, similar demographics. And imagine in both the cities, 200 patients end up with M1 occlusion. And Gotham City has got like Batman, well-organized system, centralization, get to the BAT hospital, good workflow, tested devices. And 120 patients go to the cath lab, and 66 of them have a good outcome. So essentially, based on the way that we are describing our results today, 55% of them had good outcome. And imagine another city, which is like Superman, Metropolis, complicated system, multiple hospitals, drip and ship, complex workflow, multiple tests. And finally, they take 20 patients to the endovascular suite because those were that fitted the criteria. And 18 of them had a good outcome. And if that was true, the person who did this would come up on stage right now, oh yeah, my thing is better. I got 90% good outcome as opposed to you guys who just got 55% good outcome. But is that really the truth? Is that the truth is that you have to choose the correct denominator. And if you choose the correct denominator, in Gotham City, 33% had good outcome, while in Metropolis, 9% had good outcome. And this is exceedingly important as we move forward, because to impact on society, we have to choose the right denominator. And time is brain. Bruce mentioned this earlier. The single biggest important thing is going to become onset to recanalization. And as we move that faster and faster, what will happen is, even though we may percentage-wise have a slight drop, but our impact on society will be more. And this is an important concept to understand where as we developed criteria for, so to speak, registration and certification of a comprehensive stroke center, that we choose the correct denominator. Because otherwise, what will happen is that people will tend to sort of say, okay, well, minus 60%, minus 50%, but the denominator is not correct. So essentially, what does it mean? What it means is the only way you can achieve it is you get to the correct hospital early, and then from there on, the processes seem to be quite good. Imagine a situation where there's an M1 occlusion, and 1 minute later, you could open the vessel. If 1 minute later you could open the vessel, that's when you would have 100% efficacy of treatment. Because at that point in time, the core would be 0, and essentially, that is what we have to aim for. So forget about imaging criteria, forget about all that, that'll get established and stuff. This is what we need to collectively work on, and to my mind, this is the single most important thing that we need to work on, get the denominator right, and get patients to the correct hospital early. Now, this issue of drip and ship versus mothership, there's this sort of cheesy kind of TV show called Numbers, in which this mathematician solves murders using mathematics, and I was seeing one of the episodes. It gave me this idea that essentially, if the patient goes to the wrong hospital, gets TPA, gets transferred over, a certain amount of time is spent. If they comes to the mothership, what happens is the TPA gets delayed by an X amount of time. And to my mind, now it is a plain and simple mathematical question as to how do you shift it in terms of what is the distance or the time that needs to be before you would say that a direct mothership is better, or is it better to go to drip and then ship? And in a place like Canada, which is massive, low population density, we could come up with a situation where we say drip and ship is better. However, in a place like, which is densely populated in a smaller country like South Korea, it may be just better to forget about drip and ship and just go straight to the mothership. And I will work on it mathematically. I'm working with some of my friends, Bijoy in the crowd, and we'll come up with a mathematical model in which we'll be able to say that this is the inflection point of that this will work better or this will work better. I'll give you some of my personal perspectives. So the last 2.5 years has just been an amazing time from my personal point of view in terms of helping run Swift Prime and ESCAPE, designing these trials, going after meeting people, going to centers. It's just been an amazing experience. In the process of all these trials, I ended up traveling to 35 stroke centers. Any stroke center that I went to, I would convince them, say, okay, take me to Emerge, where does your patient come in, walk in with them, say, okay, now what happens? Now you go to imaging, now this happens, now you take a decision, And it came up with, like, in the sense, it was amazing in terms of how many good things are across and how many sort of friends I made in the process, how many things I learned in the process, and the kind of problems people are struggling with. So I was at this one particular center, and the stroke patient comes in just by chance at that time, and we get the CT done and stuff. And then we are waiting for an elevator, because the cath lab is on a different floor. And we're waiting for an elevator and things like that. And there is no special key to say, OK, everyone move out. We're going to take this patient up. So those are the kind of things that one has to struggle with. I could fill my talk or the next 3 hours with anecdotes of all the visits that I did. But the other thing that really struck me was this idea of it's all about people. Yesterday, people who heard me, I told a little bit about Chattanooga. I'll tell you another example, this time about Dublin. So I had no idea about Dublin, didn't know them. They heard me talk about multi-phase CTA here and there. We met them at London ISC. We got talking over coffee, and they asked Michael and me, well, why don't you come and visit? And then when we visited them, from there on, we've interacted with them multiple times across the trials. It's just been an amazing experience, an amazing set of people committed to stroke, really, really a great center. So the other thing I came out of this was that the process of creation of a center of excellence is not related to the nameplate on your institution. It is related to the people. A group of people come together, and they create a center of excellence. And from there on, things just take off. So I don't know if anyone from Dublin is here or not, but thank you guys. You guys were amazing. So. In terms of sort of, as I told you, I met amazing people along the way and learned a lot from many, many different people. Many people worked super hard, and there's no way I can name all of them. So I'm just going to name 2 people that I'm going to talk about a little bit that I worked very, very closely with. I'm sort of a leader, read a lot about history here and there, read all kinds of different things. So one of the things that I found in this person here, as I read about him, was that his ability to get people together, achieve consensus, and move on. And I worked really closely with Jeff Saver through the process of Swift Prime. We probably chatted 3-4 times a week, text, emails, this, that, and the other. And Jeff has this amazing, calm way of just slowly just working through it, achieving consensus, and saying, OK, this is how it's going to be done. And it's just a pleasure, Jeff, to work with you. The other person I'm going to talk about is Michael Hill. Michael and I, it was just an unbelievable, real privilege. Michael and I traveled everywhere together, and we were really short on money. So everywhere we stayed, we used to share rooms. So it was just, we spent a lot of time together, and I'll tell you a couple of stories about Michael. So one of the things was that Michael, wherever we went, gave his personal cell phone number and said, call me for every patient. Last 2 years, 24/7, Michael has been available on the cell phone through and through, other than when he's in flights, anytime, day or night. Call me, I'll help you randomize, I'll help you get through it, I'll help reduce errors, and things like that. So Michael starts to train to run a marathon with his daughter. He's going for a run. He gets a phone call from Montreal, from Danielle, and they have a patient, and they're sort of struggling with it. So Michael picks up the phone, and Danielle says, are you having a stroke? So because Michael is totally out of breath and sort of struggling to breathe while he's running, and so these are the kind of sort of, I can tell you lots of stories about Michael, but Michael, amazing to work with you. I'll tell you one other tiny little story. January 15th, 5 p.m. is when our blind opened, in terms of finally the last patient was seen. January 18th, 10 a.m., we submitted to NEGM. 60 hours, Bijoy, Andrew, Michael, and me, we basically sat in a room, and we did the entire analysis. There were a few people who came in and out sort of thing, and we wrote the paper, we revised it, we submitted it, and essentially, all of us were collapsing at a certain stage, and we would sleep get up, start working again kind of thing. But essentially, Michael probably went straight 60 hours without sleep. So, Michael, amazing work. So. In preparation for this, we wrote a lot of stuff, trying to get everyone going, things like that. Worked with a lot of you here in the crowd. Talked about imaging, talked about decision making, talked about the need for trials, talked about this, that, and the other. And that was sort of a great, amazing experience in clearing my own thinking about the process. I don't see Elad here, but for me, as this trial process started, we were already doing this for 10 years. And it was a real personal struggle for me to get past this process and decide that this trial needs to be done. So essentially, we wrote this editorial. Many of you are there. Jeff, Michael, Bruce, we all wrote this together. Challenges of acute endovascular trials. And we wrote this talking about everything. But as has been mentioned earlier, the single biggest challenge looking backwards was the randomization. And you've heard 4 of us talking up here on the stage, but actually, the single biggest challenge was randomization. And I'd like to end this session with a hand of applause for all of you who actually went and did the toughest part of this thing, of randomizing people. Thank you very much.